that's a really nice introduction that you gave me there. You know, it's funny to listen to somebody talk about your work and you know, think back on all those things. And I really have had a great opportunity to work in the alcohol and drug field for a long time. It's really been my passion ever since I was uh, a undergraduate student in college. And so it's kind of fun now to be able to go back to that same college and teach in the program that I graduated from. So, Philip, does everything look good as far as the screen and sharing things?
Yes, looks
Sure.
good over here.
All right, good. So what I'm going to talk to you about today, and I did get to present on this, like Philip said, at the State of the Science meeting in Florida, which was just a fantastic event, and I learned so much from all the others. But my topic is investigating opioid and alcohol risk and misuse among rural agricultural workers. And I kind of found when I was at that meeting that some of my constructs and ideas around agricultural workers are a little bit different than maybe some of you out there who are listening. And so I'll talk a little bit about that and the population that we work with here in my neck of the woods, which is in Nebraska. And so I want to tell you a little bit about who I am and where I'm from. This picture of the map is where I'm from. I'm right in the middle of the country here in Nebraska. Sometimes people don't really know where Nebraska is because we don't make a lot of news. We're a pretty quiet little state here in the middle of the country. We do a lot of agricultural production. Our main economy is agriculture. And so it's really important to our state to understand and support the folks who grow our food. And so that's where I'm from. Right now it's snowing out my window. I just looked and we've got some snowflakes coming down. I was telling Philip we've just come out of an ice storm the last day. So it's very cold and slippery and not very fun. But that's winter in Nebraska. And then the bottom picture is kind of who I am. And I always like to I guess share a little bit of who I am, because not only professionally does you know, is my identity. I'm a teacher, I'm a professor, a counselor, and all those things. But, you know, I have a great support behind me, which is my family. And so that's my daughter's wedding, which we had here in May. And, you know, I said Nebraska doesn't make the national news very often. We did make the news around the time of her wedding because we had some terrible flooding in Nebraska. And the place where we were going to have her wedding was flooded. It was on the river, and we had those massive floods, and we had what was called a bomb cyclone. So half of our state was struggling with a blizzard, which kind of destroyed some of the cattle industry in part of our country, because the baby cattle were being born, and it was blizzarding so bad that they couldn't get to the cattle. So a lot of people lost their cattle. Out in the western part of the state, and in the eastern part, we had massive flooding along the Missouri, and then up north, a dam had broke on a river, and so many people, you know, lost their homes, their livelihood, their crops, their fields. You know, we had this wedding planned, it got flooded out, but it was nothing compared to what some of our agricultural folks have been going through. And so there's a lot of stress right now in terms of the agricultural community, and just a lot of concerns about people are handling that natural disaster. And I know in Florida in particular, where a lot of you are from, you've had hurricanes and other things you've struggled with this natural disaster stuff for some time, and we just haven't in Nebraska. So it's been a real trial for folks. And, you know, not only, you know, obviously on the kind of the production side and how that impacts fields and such, but also emotionally. It's just really hit our farmers pretty hard. So it makes the work that we're doing all that much more important in terms of agricultural mental health. So this is another picture of where I'm from, and just to give you a sense of how rural that it really is, this is the main street of the town where I grew up, and It is very rural. It's in the western part of the state. It's actually called Frontier. You know, that my town growing up only had about 5 people in the middle of the state that only has 500 people, and it's very small. And you know, you can see the picture there on the top. We have what is called the Sandhills, and it's the kind of the world's largest um, desert. Used to be a desert, and now so it's just sand dunes that are covered with grass for hundreds and hundreds of miles in the middle part of the state. You probably drive 2 hours and don't hit a town. You just see a lot of cattle. And so I just wanted to emphasize kind of the structure of our state and what it looks like. And these are the people that we are trying to reach and help through this research that you'll see in a minute. So I do get to teach at the University of Nebraska-Kearney. I teach in the counseling and school psychology program. And so this is what I do. I get to teach counselors how to work with folks, how to do diagnosis. I teach clinical classes to help counselors go out and work with folks. I also get to teach in the medical school and help medical students and physician assistants, doctors, nurses, how to do assessments for things like substance use and mental health screenings, because that's something in our rural part of the country, we don't have a lot of counselors. We have a lot of medical folks who work kind of double duty, really, in physical health and behavioral health. And we do have another unique thing in terms of behavioral health in the workforce. I'm the associate director of a rural workforce center that focuses on behavioral health education. And so we're pretty unique in that there's only one or two of these across the country that looks at developing the behavioral health care workforce. We have a shortage, and we have for a long time, just not enough folks to do the work. So we're trying to build up that pipeline. So I do get to teach research, and that's a fun class to teach for students who don't particularly care for research. I know some of you I saw on the list are epidemiologists and also teach and such. And so, you know, it is something that I love to teach, but yeah, I teach it from a different viewpoint. And so you can take the country out of the girl. But, you know, my lens is rural. And so when I teach the normal curve, right, I show them the grain elevators outside of my town. That looks like a normal curve to me, right? So it's just everything, I think, as far as my worldview and lens really does have to do with agriculture. And when I said that maybe our state is a little different in terms of agricultural workers, what I learned when I was in Florida and at the conference, that there's a lot of variation in how we define agricultural workers. So I wanted to define my population and what agricultural workers are in this study. So in Nebraska, this would be a typical farmer, right? We have a lot of corn, soybean, wheat farming that we do. And so most of agricultural folks here are owner operators. And so they own their own farms and operate in, you know, there's families that have done this for generations. And so a lot of our agricultural folks are very educated, they've gone to college, and, you know, come back to the farm and work. UNL, our sister institution, trains a lot of, trains, I don't know if that's the right word, but they have a really large ag program. And so kids graduate high school, you know, go and get an agricultural education, and then they come back to the farm. And so when I'm talking about the folks I'm surveying, these are the folks. They're not so much migrant. We don't have a lot of migrant workers, although we have a couple pockets. We do have meat packing, where one of the studies was done in a town where there's a meat packing plant. So there are some more, not really temporary migrant, but folks who have moved here from other countries, mostly from Mexico, South America, and a few pockets of population from Sudan who've come over and worked in the meat packing. But for the most part, our folks are owner-operator farmers and work the land and have cattle as well. So when we look at the scope of the problem on my topic for SUD, which stands for substance use disorders, and mental health statistics, I think it's really crucial that we understand the background and the scope of the problem that we're dealing with and how that might look the same or different in rural populations. And so if you look at folks who have substance use disorders, this data comes from the National Survey on Drug Use that they do every year. And you're probably familiar with this report or have seen a report. It's a national report. And so when we look at the folks who have within the past year have a substance use disorder, so as in 2016, you see that there are a number of people who struggle with this, 20 million people, 7.5% of the population. And when you break that down further, you can see that alcohol really is the #1 substance that most people use or abuse. And then illicit drugs, marijuana, prescription medications, and then on down the list. And so although we've seen a lot of national attention on the misuse of prescriptions and those, heroin, really alcohol is the #1 drug that is abused and actually causes the most damage. It is a legal drug, so that is why I think we don't really notice it as much because it's become very normalized in our culture. But that is kind of the #1, if we look at in terms of numbers, substance that is the most concerning. And so of all those people, right, who are using substances, this chart breaks down the people who need or who are needing and receiving treatment, which this is where I get concerned as a provider. So you can see the numbers across the bottom there. Really, it's the 18 to 25 group that really needs the most treatment. 15.5% of the people need treatment. Only 1.8% actually receive that. And so, not very many people get the treatment that they need. A variety of different reasons. One, maybe they haven't been identified. They don't, haven't, really had an opportunity, been made aware of options for them to get treatment. The other, though, is when they do need it, it's hard to find and it's hard to access because of lots of different reasons. Payment is a huge issue. And so that is something, especially when we look at rural, is an issue. So, and I said alcohol is the kind of the biggest issue that we have in the country. You can see this chart breaks it down by state. So if we look at excessive drinking, which they define as binge drinking, for women, it's more than 4 drinks in a setting. Men, it's more than 5. And then they also have another category, chronic, which ups the drink totals in a sitting, more than 8 for women or more than 15 for men. It's different for men and women because men and women tolerate alcohol a little bit differently. Women don't as effectively break it down in the body as men do. And so that's why the difference in the numbers. But you can see Nebraska is one of those dark blue states, and that dark blue is higher than the national average. And so the average across the United States is 19%. In Nebraska, we are at 21.7%, so 4th highest in the United States. And you can see some of those other states are close to us, and also have a pretty large rural focus. Think of Montana, North Dakota, Iowa, very rural kinds of states. So the other issue that we're looking at in most of our studies is opioids and the prescriptions. A lot of funding now, as you probably know, really has to relate to the opioid crisis. And so we want to make sure that we are addressing that as well. And so there's been waves of this opioid crisis. The first wave was prescription opioids. People, struggling with the prescribed, either overusing it or using it in ways that have not been prescribed to them. So you can see the overdose deaths is what this chart looks at, and the first wave, moving into the second wave, kind of stayed steady in terms of if you look at heroin or other synthetics. And so, but it was the prescription drugs that were climbing. And that's what got everybody, everybody's notice and attention. And so now we look at, we're in the third wave, which the commonly prescribed opioids, or the the medications that you would think about if you go to the doctor and you have some pain, oxycodone and all those kinds of things. It's kind of leveled out a little bit. And what has climbed in this third wave is the synthetics, which is the fentanyl and other manufactured or illicitly manufactured medications have really skyrocketed since 2015. And heroin overdose has also climbed. And as we have gotten a handle on prescriptions a little bit, then folks are switching to other means of dealing with their opioid use disorder problems, which is going to the more illicit types of drugs. So we see a huge spike in that. And we'll discuss in a little bit here the overdose and why that particular spike is happening with those medications. But what are these opioids? One of the things that we have to do when we go out is when we ask folks questions about their use of opioids, they don't know what that really means. And so we're doing a lot of education on the names and what opioids are in the different forms. And so this chart, right, prescription opioids are those things that the doctors can prescribe, oxycodone, hydrocodone, morphine, methadone, which that's pretty specific to treatment for substance use, opioid use disorder, actually. Those are the names of them. Tramadol is another one. And then we look into the next wave, the synthetics, which is the fentanyl case. And fentanyls are synthetic opioids that are very, very powerful. Most of the time, they're used when people go under anesthesia because they are very powerful. And cancer patients use them for very, very severe kind of palliative care, end of life things. And then we have heroin, which is the illegal form, I guess, that is, I guess we would commonly think of it as more street drugs. Very, very addictive. Once somebody takes it, it doesn't take very long for them to become dependent on it. And so these opioids in these different forms, the overdose potential just increases as we move from prescription to heroin to fentanyl. And you can see on the screen, those vials are the amount of the substance that it takes to overdose. And so heroin, it fills the bottom of the vial, fentanyl, just a few little grains, and carfentanil, just one little grain. And carfentanil is in that class of synthetics. Carfentanil they use a lot as an elephant tranquilizer, so it's very, very powerful. And that's why the overdose have skyrocketed, because it does not take very much for people in their system to overdose. And, you think about in Nebraska here not too long ago, we had the largest seizure of fentanyl it come off of the interstate right close to where I live. The troopers pulled over a car and for speeding and found a whole bunch of fentanyl in there. And so if you hear about, they've seized 100 pounds of this or 1,000 pounds of this or whatever it might be, that that all of that is so lethal because it just takes a few grains of that to overdose. So another awareness thing we're trying to do is get folks to understand kind of the scope of the problem. So the opioid prescription rate, some states have had more of an issue with this than we have in Nebraska. And you can see that the states here that are in red, I really was curious about kind of the supply, what is out there in terms of prescribing, because we've done so much work on a national level to get those prescribing rates down. And so the overall national rate of prescribing is about 5%, 5.4 for across the country for prescribing things like oxycodone and those prescription medications. We're a little bit higher in Nebraska. And you can see some states are really high. The red states are really high. The yellow states are lower. So you can see Florida is in one of the lower rates. And I know there's been a huge focus on that, mainly because of pill mills, right? That have popped up, and they've now, started to get a handle on and shut those down. And so that prescription rate has gone down. We have not gone down. We haven't had any pill mills here. Mostly it is our prescribing rate's high because farming has a high rate of injury. And so, back before kind of this opioid crisis, lots of medication was being prescribed because that was the best practice for pain. And so doctors, frequently prescribed it. And I think, that's getting a little bit better, trying to understand other ways to do pain management other than just medication. So the prescribing rates are concerning for us. The other thing I would say is for us, the change in overdose death rates. This is another stat we kind of look at. We don't have the high rates or the high numbers like some states do, but our rate of change has increased tremendously. And I don't know if it's because we're getting better at tracking it now, or if we've had more people who are actually, increasing in what we're seeing in overdose. It's the jury's out on that one from our epidemiologists, but they are very concerned about it, as we are. So when you're looking at a 48% change of rate in an overdose deaths in a year, we get kind of concerned. And we do have a little bit of a higher problem, like in Omaha, some of our urban areas. That's a lot of where we're seeing some of the heroin. So that also could be driving this. All right, I seen somebody had a chat here, and so I would definitely be fine with looking at those as we go along. Just going to read this. Lowest rates now. Yes, I do agree that the overdose rates where it's been really high, they now have lower rates of prescribing. And I think that's because some of the policies have been working. Some of the things that they've tried has been working, which is fantastic news. It really, really is. My concern is that though, as those folks, are now not able to get their medications, they're turning to the illegal, the heroin, the synthetics, which again, you see the spike in overdose deaths coming from that category of substances. And so, it's kind of goes back to that very earliest slide. We want people to get into treatment to be able to get a better quality of life, right? Rather than using these substances. So, but that is really good news. I would agree with that. So this chart looks at the rural and urban substance use comparisons. I was very curious, of course, because we live in a rural state. I just spent all that time showing you how rural my state was. So, we want to think, is it any different in rural America? So this chart looks at alcohol use and prescription misuse of opioids, marijuana, some other substances by classification of size of the area. So non-metro would be our real rural folks, and even some frontier. And then small metro would be a little bit more um, rural. So I live in a town of about 30,000, and that would be considered small metro. And then I should say I work in a town of about that, which would be the small metro. And then large is what we would think of as being urban. So you can see it's pretty uh, consistent in some areas. Some we have more. Again, look at alcohol. The more rural you are, the more alcohol use there is. If we look at misuse of prescriptions, it's about the same. Actually, it's less the misuse of opioids. So again, you know, in my investigators, I'm like, okay, something is happening here. Alcohol seems to be something that we should be focusing on in our rural areas. So why is that? So the farmers uh, union did a survey, and you can't find a lot of data on this. I mean, there's just a few little pockets of information. And so what I did find was the farmers union did the survey of their members, which American Farm Bureau is pretty big, and the respondents, 74% of them said they've been directly impacted by the opioid crisis. And so impacted meant either themselves or they knew somebody. Massachusetts did a study of opioid-related deaths in farming, fishing, and forestry, and they found that was 5 times higher than other workers. And so, you know, you think about it of Massachusetts and, you know, what their kind of industry is. It looked like a lot of it was the fishing and, you know, having another high rate of injury in that field, but 5 times higher than other workers. That's quite a bit. Rates of drug overdoses are rising in rural areas, the CDC reports, and the farmers are at risk for substance use disorders due to the higher rates of injuries, stress, and lack of awareness. And we sure see that when we go out and we talk to folks, just not as educated on some of the risks as maybe we would like them to be. So, well, I was talking about Nebraska having a shortage. In our state, 88 of our 93 counties are considered shortage areas for behavioral health providers. So some of that lack of information is because we have such a shortage of folks who actually do the work. And there's a lot of stigma around that as well. So we did a poll through our Nebraska Rural Health Poll through our university. And it's kind of astonishing to me that a lot of Nebraskans endorsed that the following items there bring shame to a person. So if going and getting treatment, 45% of people believe that brings shame to somebody. So even if we could get folks to treatment, there's still this huge stigma around receiving that help. And then seeking mental health care was a little bit more, and going to drug treatment was a little bit more shameful. They consider that to be shameful rather than helpful, which is a huge barrier. If we can actually get people to go, then there's this lingering, how are they going to be accepted by their community, right? And it's a small, tight-knit communities that they come from, so everybody knows. And that really creates a barrier. So our projects here, getting into some of our data, we have done several different projects surrounding this, as funding goes and projects become available. We've tried to utilize those resources and maybe more for change, some of our projects to gather data. So I want to talk about 3 different things that we've been doing. So to understand our projects, you got to understand what SBIRT is. So our first study, and I say we because I've got lots of people behind me doing this work. We have, one of the things that's been important for us is to have champions or partners in the communities that we go into. So in this particular study, we're in a medical setting, and so we have a counselor, Jason, who helps us with that, actually embedded into the clinic. We have an epidemiologist and who does some just fabulous work on, understanding contextually and more from prevalence rates and things like that. helps with data analysis in the graduate student. So this particular study was trying to get screening and brief intervention into rural medical clinics. And so the clinic that we went into, the background of the clinic, this is the community that has a large meat packing plant. And so it's called Tyson Foods. And they employ, many, many people. The town is about 10,000 population. A good majority of those folks either work in agriculture or at the meatpacking plant. And so the demographics are unique in Nebraska because it is, Nebraska is predominantly Caucasian. This community, though, you can see it's just a little over half. And there's a large, when you look at Hispanic of any race, right, that 60% of folks identify as Hispanic. And then there is a larger African American population because these are the folks that come over, refugees from Sudan who come over and work in the meatpacking plant. And so the medical provider that we work with does a lot of work with the employees of the meatpacking plant. They have a contract there that helps them get their physicals and some other things, immigration stuff. And so they do routine screenings as for substances as a part of that practice. And so the other project that we are doing is taking the screenings out into the field. So this is pretty preliminary and unique. So within the clinic, we were doing screening and brief interventions. And what that really means is that we have 2 instruments that we use, that we screen for substance use, and then we provide a brief intervention, so telling them what their risks are, and then if needed, a referral to treatment. So we're trying to tackle, the awareness piece and the intervention piece and the treatment piece all in the same intervention. So that screening and those brief interventions are pretty short, actually. It's probably like a 5 or 10 minute encounter. And so we're taking those same screenings and we are taking them into agricultural work settings or, places where agricultural folks would go, such as farm shows, ag conferences, so places outside of healthcare. We're trying to reach that population. And this project, we have a few different researchers on here. Epidemiology, the same researcher and I are on it, as well as my grad student. And then we've included some public health folks and extension. And so the extension agent does a lot of outreach into the community. And so she's come on board and gotten trained in how to do these screenings. And we've done some of these out in our, around the state. So this project, we really is more like a feasibility study. How is it going to work? We weren't sure with the stigma that you heard about, like, are people even going to be willing to talk about this, take the screenings? We want to determine some prevalence estimates for our state. And our data collection was the screeners. And we mostly found that paper and pencil worked the best. We do have some mobile or iPad type situations that we've set up. Most people don't care to do that. They really like the paper and pencil, which is interesting. So we are shooting for 300 in our target sample size. We're about halfway through the project, and we are running a little short, but as you'll see in a minute, we've got some bigger events coming up that we'll make up for that. So I talked about SBIRT a little bit, and it is, if you look it up, if you're interested in it all, you just type in SBIRT, you're going to get tons of information. It's endorsed by SAMHSA, the Institute of Medicine, Medicaid, the American Medical Association. Many, many websites are devoted to it. It's an evidence-based practice that helps identify and reduce substance use dependence. And so it's pretty easy to implement. And in medical settings, it's easy. And actually, we found it's pretty easy to implement in other settings as well. So the screening just quickly assesses the severity. And the good thing about the screening is it's the person's own information. So it is personal. You know, it's not just here are the limits. It actually makes that person look at themselves and then pair it to what's recommended. So it has a little bit more, people have a little bit more buy-in into it because of that, because it is their information. Brief intervention is just that awareness and insight in helping people maybe move towards change. And then referral is those, you know, moving folks into more specialized treatment if needed. So when we do this, we have to educate the person when they're filling out, especially the alcohol one, on what a standard size drink is when they're filling out the questionnaire. Because most folks, you know, like everything else in our society, it's gotten bigger, right? And so what a standard drink is 12 ounces of beer. If they're craft beer or, you know, home brewed kinds of stuff, the alcohol content is higher, so it's less. It's 8 to 9 ounces, 5 ounces of wine, or about 1.5 ounces of hard liquor. That determines one standard drink. And, you know, it asks you on this screening, how many standard drinks do you have in a week? And so, you know, you have to think about, well, if it's 12 ounces of beer, you know, I drink bigger ones. So I've got to, if it's a 24 ounce, then that's 2, not just 1. And so that's because a lot of times in our society, right, this is what people are consuming, right? And because it just kind of, the portion sizes, like everything else, gets out of hand. So we have to help them understand what that looks like. So when we get the scores on these things, that's pretty quick, maybe just takes a few minutes. We get a score of what their risk is, either low, moderate, or high. You know, there's cutoff scores, and based on that score is the intervention. And so if it's low risk, there's even an intervention point, which is positive reinforcement. You know, that's great. You're within the guidelines, you know, and it's, you know, good for your health, and keep doing that is the message that we want. You know, don't increase, keep doing that. If it's in the moderate, we do the brief intervention, which mostly we talk about and show them what harms alcohol or any of the other substances do in the body, to make it a little less, I guess, judgmental. I think people a lot of times when they're talking about their substance use feel judged. And so we try to take a very medical approach and reduce that judgment by saying things like, you know, alcohol can impact your heart functioning or liver functioning or stomach. And then we also do put in there a few of the more social issues or psychological issues, which would be, you know, difficulties with family, problems in maybe with friends, that kind of thing. And high, obviously, then referral to treatment. And we do have cards and places and numbers that folks can call if they want to follow up. So our preliminary findings, this is in the medical setting, and we're still analyzing some of the data. Just had a meeting yesterday about kind of capturing some more information around follow-up for folks. And so total seen in the clinic for this time period was just around 4,500 people. And the breakdown in gender was pretty even. A lot of folks still in this clinic, even though this is the one that's in this town where there's the meat packing plant, mostly Caucasian, but we are capturing about half of the Hispanic population, and right around what the community would look like in terms of African American population, or African, really. And then marital status, you can see that employment. The insurance, most folks have the private insurance through the meatpacking plant. So out of all of the people that were seen in the clinic, about 2,700 of them were screened. And you can see that that for a behavioral health disorder, we had 60%. So that was pretty good, we felt like. But when we got down to being screened for substance use disorders, only 1%. And that was very concerning in terms of why that screener was not used in the clinic. We have done some follow-up things for that. Sorry, I didn't mean to go forward. We did a focus group with the providers so we could understand why that screener wasn't used. And it was interesting, many of the providers indicated that they felt very uncomfortable giving that screener to their patients, that they did not feel like they wanted to open up that can of worms, somebody said. Even though it was a healthcare setting, and that would be a valid question to ask about their substance use and how it was impacting their health, it was not something that the providers felt comfortable doing. And we had not really anticipated that. We went in and trained them. There was a little bit of uncertainty, but there was agreement to use it. But then when it actually came down to it, they were not using the screener. And they felt that the patients would be offended. And so again, we have a stigma kind of rearing its ugly head. But of those 65 that got screened, and I will tell you, this data, we continued the project for 2 months after this. And so that's the data we're looking at and hoping to see if it helped after we went in and did an intervention with the providers to see if they used the screener more. But so those screening results for those 65, mostly you can see there was alcohol was number one in terms of what they screened positive for. And then tobacco. This clinic wanted this particular screener because of tobacco, and so that was pretty high. Stimulants was high. We do in Nebraska, methamphetamine is our number 2 substance that's abused here, so that's consistent. Opioids was 35 and marijuana was 29. So, and we're not a legal state for marijuana, so the prevailing social construct around that is that it's still illegal. So in our agricultural settings project, so the other one, we had 10 screening events up to this point with 104 folks screened. So we do have several events planned yet before the end of this project, which are pretty large events. Typically around here, a lot of our larger screening events are in the winter, January, February months, because that's when, farmers can have some downtime. And so out of the 104, our age range was anywhere from 20 to 87. We did find that a lot of folks that go to the farm shows and such that we've been to are retired. And so we hadn't anticipated that either. So we are going to change it up for our next round of application, and this we have another grant to extend it. And we're going to change up the venues and see if we can get folks that are in kind of in that younger category that we looked at before, maybe some younger farmers, see if it changes the data at all. But out of there's 2 screeners we use. The DAST is a drug abuse screener, and the audit is an alcohol screener. So in the DAST, or the prescription medications it talks specifically about, 93 of the participants scored in the low risk category and 10 scored in the high. So we're right at about a 10% high risk percentage. And it was the same with alcohol. So in some respects, that surprised me a little bit in terms of it being the same percentage. I would have thought or predicted that alcohol would have been higher because of the numbers of binge drinking and some of our lower statistics around overdoses and those kinds of things. So it's about the same, which it is interesting in terms of Nebraska is still a high prescribing rate of prescription medications. And so in the farm community, we're seeing that there is a little bit more of a risk, higher risk than what we would have predicted. So for consideration, I guess what do these preliminary results tell us, and what kind of are we going to do again? So future work, we have been funded for a couple more projects to keep collecting data to make more definitive statements around opioid and alcohol risk in rural communities. We are doing an ongoing scoping review right now for farming and SUDs. And in that, again, a lot of the reviews that have been done have been on a migrant population. And I know a lot of folks in, at least in Florida when I was there, that is really your population, right? A lot of migrant farm workers. There's a lot in the literature that talks about that being a very high risk population and a lot of use of substances. And so again, there's this gap. What do we do? What do we know about farmers, such as who we have in our state, that are owner operators, that are in a different population base? And then we are waiting on to hear on some funding for NIH grant to continue our SBIRT implementation at rural clinics. SBIRT's been done a lot in more urban settings, but not in rural settings. And as you heard, it's hard in rural communities. There's a lot of stigma around, we don't want to implement these screeners because we don't want to talk to our patients who are also our neighbors or maybe our banker about their substance use. And so we feel like there's something there to be further investigated. So my contact information is there on the screen. If you have any lingering questions, follow up. I do see that somebody has chatted here, so I'm going to open that back up. Yes, was any more age group at risk than others? That's such a good question, Kara. I have not broken that down specifically. I think that is something that we definitely do want to look at in terms of the ages, given that the 18 to 25 is what we would expect, but that we had a lot more in the retired group. I think that's a fabulous idea to break that down and look to see, is it the older folks, and is it the older folks with the prescription medications, or is it the alcohol? And so that will be something that we will look at. So that question probably helped me more than it helped you. I will pull up my chat again if anybody would like to chat. And Philip, I don't know if you're going to monitor the questions or not, or if you just want me to read those. I am able to see them, so.
Yeah, no, I think at this time, we'll just remind everyone, if you have questions, use that chat box or just some comments. Go ahead and type those in. And Dr. Chasik, as you see them come in, you're more than welcome to just answer them. Absolutely.
Oh, great. Okay. So I see Rick asked, the slide showing change in opioid overdose, Montana had a drop. Yeah, that was really interesting. And I don't know what Montana is doing in particular. That I know that there's been some, a lot of grant work that has happened, and a lot of extension folks have implemented a lot of awareness campaigns. And so I would have to do some more research into Montana specifically to see what they've been doing that works, for sure. That is important. I know some of those states that were on there, their drop was, had a lot to do with closing down pill mills, which was a heavy focus early on. And I know law enforcement has been doing a lot in terms of policing the illegal substances. And so that could also be impacting that. And also the CDC and the medical community, prescribing guidelines have changed, training has occurred. In Nebraska, we've gotten funding. Every state has gotten funding around it's called the State Targeted Response to Opioids. In Nebraska, we have used a lot of our money to implement what's called Project Echo. And an echo is a very unique intervention, which is telehealth on a large scale. And so there's a expert panel that gathers, and we do a webinar such as this, only we use the webcams and everybody can see each other 2 times a month, and do some type of very brief didactic training. So it might be on overdose, like how to use Narcan for medical providers or first responders, or it might be around how to talk to patients about their pain, just a variety of topics, mental health and substance use co-occurring disorders. And so we do just a brief treatment, and then people can send in their cases. So if they're working with a patient and they're struggling, with how to treat that patient, they will do a consultation time. And so all of these rural providers, can get access to specialty care and knowledge by joining in on the echo. So rather than sending your patient, all the way across to the state to the, special clinic that treats opioid use disorder or, any other alcohol use disorder, people in their own community can provide the care with consultation. And has a lot of research around it, that helps to reduce health problems. And they've done a lot of echoes with hepatitis and all kinds of medical issues, and we're just starting to use it with substance use disorders. So we have physicians, counselors, community health workers, all kinds of people joining the echoes to get information and to get recommendation and treatment ideas to help with this particular issue. So I do wonder if maybe, Montana might be doing something like that with some of their money, that they've seen such a decrease. So good question. Any other questions in terms of, this topic? I'd be happy to answer. Again, I'll pull up my slide with my contact information. And you certainly can reach out to me via email is the best way. So I put my email there. And I'm just so happy to be invited to talk about this to my colleagues, who live in a different part of our country and do different kind of work. It's all so important to deal with, I think, agricultural mental health and substance use disorders, because it's just something that we don't talk about enough. The more we talk about it, the more that we study it, the more that we intervene, I think the more we'll break down that stigma.